Uh, Good afternoon, all. The course still remain reproductive health. We shall be discussing safe motherhood today. And we all know as midwives what safe motherhood means. The concept of safe motherhood means ensuring that all women receive that the care they need to be safe and healthy throughout pregnancy and childbirth. It also encompasses social and cultural factors as well as address health system and health policy. The initiative. Safe Motherhood is an initiative that guarantees a woman's successful completion of the psychological process of pregnancy and childbirth without suffering any injury or loss of her life or that of her baby. The other approach to safe motherhood is 1. Making pregnancy safer. This is WHO new strategy to safe motherhood. It is a strategy for action recognizing that an estimated 50% of women in the world do not have access to such care, who decided to concentrate on assisting countries to achieve their safe motherhood goals. That is by making pregnancy safer initiative is one of the 11 priority areas of the WHO organization and objectives. Also, the second one is to reduce. This is another initiative strategy by WHO for safe motherhood in 2022. Federal Ministry of Health in collaboration with WHO developed Reduce as an advocacy tool to promote the adoption of making pregnancy safer initiative. It aims at it aims and interventions are similar to SMI. Components of safe motherhood. We have about 13 of them. I will mention few, then you go and read others. Family planning services to avoid unwanted pregnancy, high risk pregnancy. 2. Post abortion care. 3. Focus antenatal care, including nutrition, counseling, prevention, early detection, and treatment. We have prevention and treatment of sexually transmitted infections and control of HIV/AIDS. Prevention of mother to child transmission, communication of behavioral change, male involvement, improve female literacy. You read, I told you about 13 of the components, but I have just mentioned 5. The next thing is benefit of safe motherhood initiative. One, it encompasses the benefit of safe motherhood initiative. 1. It encompasses social and cultural factors as well as addresses healthy system and healthy policy. 2. It is cost effective, ensuring high social economic returns at low cost. 3. It improves women's health and the health of her family, but also increases the labor supply, productivity capacity, and economic well-being of the communities, ultimately having a positive impact on the economy. 4. Unplanned and unwanted pregnancy which can be interfere with women's social economic activities, thereby causing emotional and economic hardship, not only to them but also to their family, are prevented. 5. The burden of a woman. The burden on a woman associated with frequent pregnancy, poor maternal health, pregnancy complications, and caring for sick children, which drain their productivity energy, jeopardizes their income earning capacity, and contribute to their poverty is greatly reduced or averted. These are the five major benefits of safe motherhood initiative. Now, we also have integrated maternal, newborn, and child health strategy. What that means, integrated maternal, newborn, and childhood strategy is a package that addresses the six conditions responsible for over 90% of maternal deaths: hemorrhage, infection, obstructed labor, hypertension, malaria, anemia, and the most common condition responsible for 90% under five mortality are neonatal conditions such as prematurity, sepsis, birth asphyxia, pneumonia, malaria, diarrhea, disease, measles, as well as the underlying malnutrition and other more like HIV/AIDS. Justification of IMNCH strategy. 1. We have relationship between the health and well-being of the mother and child is that that of an inseparable thread. It is increasingly recognized that conditions during pregnancy and in and around delivery period is a major determinant factor of outcomes of pregnancy and child survival. 2. We have globally um, 2. Globally, countries with high countries with the highest maternal death are also those with the highest neonatal deaths. That is the global statistic. Countries with high maternal death also have the high rate of the neonatal death. Three, we have 1.36 million babies born every year worldwide. 2.3 are stillborn, and 4 million die at the first month of life. 4. Most newborn deaths in Nigeria lives earlier occur within the first week of life. 5. Lifetime issue malnutrition. Most especially now that almost every family is complaining. What do you think about the third world or the developing country like ours? Even in our immediate environment, you know what this means. People hardly have even 2 square, not to talk of the 3 square meals. Whatever they can get just to fill the stomach is okay with them. The next thing is about the strategy for maternal and child survival. 1. We have focused antenatal care. 2. We have intrapartum care. 3. We have emergency obstetrics and newborn care. 4. We have routine postnatal care. 5. We have repositioning family planning. That is child spacing. Focus antenatal. These are the strategies for maternal and child survival. If we must reduce the maternal mobility and mortality, this we have mentioned, these 5 items must be worked on or considered. 1. Focus antenatal. Focus antenatal means pregnancy outcome and newborn will help the child health are dependent on quality antenatal care. This strategy should be taken into consideration the need to increase antenatal intake and access. Okay, I observe in our state here most of these primary healthcare centers have been upgraded just to meet up with the demand of the teeming population. And health workers are required to increase their number of times during to provide these services. And most of these primary health cares are being upgraded to run shifts, that is to meet up with the antenatal care needs and deliveries. What it means, at any time you can walk in to these clinics and have your antenatal care with the skilled trained healthcare providers in that facility. Intrapartum care is the quality of care and condition during delivery. It's a major determinant factor of the outcome of pregnancy. We have the third one, obstetric emergency and newborn care, IMOG. Major causes of maternal mortality are preventable and could be easily managed where emergency obstetric services are offered by skilled attendants in an enabling environment. What it means, when you have any complicated cases of pregnancy, you just refer to a facility closer to you or close to the primary health care if it requires cesarean section or any other prompt action that could save the child's life and the mother. Then we have the fourth one, routine postnatal care. It's a significant proportion of maternal neonatal mobility where mortality occur around the time of birth and following 48 hours. We all know what postnatal means. Postnatal means the care from immediately after delivery of the placenta and membrane. That care that you render to this woman from that moment you deliver the placenta and membrane to 6 weeks or 8 weeks after delivery. What you should tell them, it means you tell them how to care for the baby, advice on discharge, follow up care. We talk about family planning, uh, immunization, diet, exclusive breastfeeding, and so forth. And those are the things we discuss in during postnatal care. As you do these things, there will be reduction, if not completely. There will be serious reduction in maternal morbidity rate. Yes, the fifth one is repositioning family planning or child spacing. We all know that we are all midwives. We know that one means after delivery, instead of the woman coming before 40 weeks, 40 days, 6 weeks, carrying another pregnancy, you'll be able to tell her she'll be able to rest the uterus, allow the uterus to go back to its pre-gravity stage. You explain to them what it means, the benefit of any family planning, the methods, and so on. When they buy the idea, it will equally go a long way to reduce the rate of death in mothers and the neonates or the infants. The strategies required for these strategies. Plus, one, recognizing the mixed opportunity for integrated family planning. Two, maximizing all opportunity for addressing men and women's family planning needs. Advocacy at the policy level, strengthening capacity, pre and in service training. We also have addressing family planning needs of vulnerable population, of the young or youths. For the then we have newborn care. The newborn care opportunity is for the continuity of care. Intervention that need to be scaled up will include access to skilled care during pregnancy. Two, capacity building, professional and non-professional staff for optimal newborn care practice. Then we have timely and appropriate care seeking for infection and care of new birth weights. Yes. And the next thing we're going to be talking about is the approach to improving maternal healthcare outcome. Well, we have ensuring access. Safe motherhood can be achieved by providing high quality maternal health care service to all women during pregnancy. Two, we have addressing gender inequality. Women's status must be improved and full value accorded to their reproductive and productive goals. Then we have strengthening outreach services and community-based approach. Then we have targeting public sector subsidies to poor family and disadvantaged areas. We have improved quality and availability of essential and emergency obstetric care. We have promoting affordable maternal health services, scale up adolescent sexual and reproductive health information and services. Then we have strengthening monitoring and evaluation. We also have child care, management of common illness and care of HIV exposed or infected children, prevention and management of child malnutrition, maternal care, micronutrient deficiency control for women and childbearing age, and prevention of low birth weight. We have immunization plus, we have prevention of mother to child transmission, water sanitation, and hygiene. And we equally have organization of maternal, newborn, and child health services at all tiers of government. Safe motherhood terms. If you are discussing safe motherhood, you hear these words are commonly used. Mortality, mobility, maternal mobility, maternal mortality, maternal mortality rate, maternal mortality ratio, lifetime risk maternal death, direct obstetric death, late maternal death, pregnancy related death, stillbirth, prenatal mortality rates, and so on. These are words that you find anyway. They are all midwives. They are not new. The words are not strange to us, and we know their meanings. Aside from that, uh, we should be talking about maternal mortality. And we stop here. Next week, we'll continue from this place. Still waiting forward to see when your class rep will call me for your assignments. Or and I want individual submitted assignments. So if you are listening to this, you can pick up your pen and write, or I should write and forward to you. I think I should do that. It will be sent to you accordingly through this channel. Then you submit individual. It's an individual assignment. I may not give you exam to write on this course. And I want you to take this with all seriousness and do the needful. But if you still decide to keep mute, there is no problem. You are welcome. Whichever one, the choice is yours. Thank you and have a great day ahead. If you have questions, you can, through the platform, you can send your questions in. But if you are answering the questions I'm going to send, I want it typed in a PDF, then submit with your name and matric number. Thank you and remain blessed. Bye bye for now.